Good evening, NATS chatters, and welcome to tonight's video chat with the esteemed Dr. Robert Sataloff. Thank you for being here with us, Dr. Sataloff.
My pleasure, Carrie.
So as NATS chatters who maybe don't know me, I'm Kari Reagan, and I'm the NATS chat host, and I would like to thank David Sabella Mills, who's on video right now with us. He's my co-moderator and dear friend, and I'm so grateful for his help with this as we learn the new video format. And behind the scenes, I want to just thank Tom Strother, who's the NATS Communications and Marketing Director, and thank you, Tom, for all that you do to make these events happen. So I had such a wonderful time researching more about you, Dr. Sataloff. The past couple weeks, I thought I knew quite a bit, but there's some wonderful video footage of you from 1987 on the CBS Morning Show, and I've posted that for our NATS chatters to watch if they would like, and also a wonderful recording of you singing the Messiah. So that was a great pleasure. We think of you, of course, as an esteemed doctor, but what's remarkable to me is also your, that you have a DMA in music. Would you mind sharing a little bit about that with us, that decision to do both?
Well, I have wanted to be a doctor from the time I was 2 years old, but my voice changed when I was 11 and was lower than it is now, and we thought I was going to be a Russian bass. So I started singing when I was 13, and my undergraduate degree is in music theory and composition. And I sang professionally really from about the age of 13 or 14. So when I finished medical school and residency, it seemed like a good idea to go back and get a DMA in voice performance. So I did that and conducted a university choir and orchestra for just under 40 years. And I still teach. Actually, my prize student at the moment just did a by-invitation Met audition 2 weeks ago, so we're keeping our fingers crossed.
Congratulations. Were you practicing medicine at the time that you were working on your doctorate in music as well?
Yes, I was.
And so I have to know what your dissertation was on.
Didn't hear you.
Your dissertation. What did you write your dissertation on?
I actually did three things. I wrote on music health and performance. I did a recital of all Russian music and did a juried concert that I conducted for choir and orchestra.
Where did your love of Russian music come from?
I studied with, well, first of all, my family heritage is Russian, and I collect Russian jewelry, Fabergé enamels, things like that. So it's sort of in the blood, but when I was in college, I studied Russian music with an extraordinary Anglo-Russian, a fellow named Alfred Swan, who grew up in Russia, studied with Metner, studied with Scriabin, and his class just left me with a lifelong passion for Russian music. He also gave me copies of Russian art song by Balakirev, much of it to poetry by Lermontov, which was pretty much destroyed when the publisher was bombed in the war. But it's extraordinary art song, at least as good as anything that Schubert and Wolf and Fauré ever wrote. So I couldn't resist the opportunity to sing that from time to time so people could hear it because it's never been republished.
Very fascinating. Well, David and I could probably sit and just chat with you the whole hour, but we should be generous with our time. And there's not one particular topic. I think if there are our NATS chatters, if you have a particular topic, let's just kind of dive in. And do, oh, David, you are going to give some instructions, and then you and I will get off video.
Certainly, yes. How are you all? Welcome to the new exciting GoToMeeting format. You should all see a control panel that is somewhere along the side of your monitor. On that control panel next to your name, under your little list of that you're present, you'll see little icons. One of the icons there is a hand-raised icon. If you click on that hand-raised icon, it will tell us that you have a question. You are virtually raising your hand. At that point, we'll put you into the queue of questions, as we can see all the people who have raised their hand in succession. And when it is your time, if you have a microphone, I will unmute your microphone. I can tell if you have a microphone, so I will unmute it, or Kari will unmute it. If you're on telephone, I can't do that. That would be, well, I may be able to. Jacqueline is on telephone. I may be able to unmute your telephone line, and you can ask a question from the telephone. And if you don't have any way of communicating with us verbally, you can type a question into the question box. The question box is like a little chat box. You see it there along the side. You can open up all of these tabs. Once you type a question into the question box, either Kari or myself will read it aloud for Dr. Sataloff, and then he will answer aloud. But if you'd like to ask a question and you have a microphone, please just hit the raise question icon, and then we'll put you into the queue. That's all. Thank you.
Perfect. So, gosh, I love seeing all these wonderful attendees and the names that I recognize. So it's great to see everybody on here. Is anybody brave enough to lead us off with a question? Otherwise, Dr. Sataloff and I will continue. Dr. Sataloff, while we're waiting for them, I actually have a question. I know you talk about with women and PMS, you talk about that it's important not to take a diuretic because that Mucinex is what you encourage if people are feeling particularly having problems with PMS. Can you tell me, I think of Mucinex as something to thin out the mucus, the phlegm. How does that work for symptoms with PMS?
Actually, I never have recommended Mucinex for premenstrual fluid problems. Interesting idea. Since you raised it, I'll think about it. But I recommend Mucinex for other things, any condition, allergy, environmental irritants, in which the mucosa, the lubrication, has become excessively thick. Mucinex thins secretions. When they get too thick, it's as if you had oil in your car engine that was too thick. Things don't work very well. Your vocal folds come together, but not efficiently. They don't pull apart right. And good hydration and Mucinex to thin secretions will help for that.
Okay.
The problem with premenstrual fluid loading is that there is extra fluid, edema, swelling, in the vocal folds, and it is protein bound. When we take diuretics, which are water pills, they diurese off, they make you get out of your system by urination, free water. So if you use a diuretic mistakenly for premenstrual fluid loading in the vocal folds, you end up drying up the surface lubrication, but you have the same swollen, boggy, unresponsive vocal folds that you had in the first place. There really is not a good medication for that. However, in people who really have substantial problems, can't sing for a few days before each period, sometimes hormonal modification, things like birth control pills, will either make the problem better or maybe even make it go away.
Okay. And are there ever, I know there are other things like you said that you recommend Mucinex for, are there any long-term concerns at all with Mucinex as a long-term aid?
Not really. It's a pretty safe drug. It's guaifenesin. Right. It's the same active ingredient that's in Robitussin without all the other Robitussin additives. It was in Entex. It is a demulcent. It really just thins secretions, but it won't compensate for lack of adequate hydration.
Okay, perfect. Thank you. Go ahead, David. I see you pop back on. David, did you want to say? I can't hear you, David.
Yes, we have a few questions.
Okay.
Oh, you should by now.
Yes.
There you go. I'm going to unmute Lisa. Let me find you, Lisa. Yes, there we are. Lisa has a question for you, Dr. Sataloff. Go ahead, Lisa. You're live.
Hello, Lisa.
Hello. I have a problem with snoring, and I was wondering if you recommend the pillar procedure for professional singers or any singers.
First of all, do you have a problem snoring, or does the other person in the bedroom have a problem with your snoring?
The other person in the bedroom has a problem with my snoring.
Have you been studied by a sleep specialist to find out whether your snoring is just annoying your bed partner or whether it is also a symptom of sleep apnea?
I have slight sleep apnea.
Okay, you have been tested, you've had a sleep study?
Yes.
Well, here's the answer. If you have significant sleep apnea, that's a major health problem that has to be dealt with. It decreases the oxygen flow to your brain when you sleep. It also, of course, makes you sleep not very well, so you're tired a lot of the time, which interferes with concentration and a lot of other things. So if we're talking about treating sleep apnea, then that's important and that's a medical issue. If we're talking just about snoring that isn't actually a health problem for you, then you have to reconsider whether you want to take any risks at all. As far as the sleep procedures go, nothing has been studied formally, to the best of my knowledge, in professional singers, and there are not any good convincing data on any of the sleep procedures, including the big ones, which are uvulopalatal-pharyngoplasty, which part of the palate is removed, the layup procedure, where small parts of the palate are removed, or, of course, the procedures where things are implanted into the palate. The common wisdom, based on limited experience and no good evidence-based research, is that the less you do, the better. So things that stiffen the palatal or tonsillar pillar areas and don't take off parts of the palate may be a reasonable first try. Partial palate procedures, like the office laser procedures, where a small part of the palate is removed and the effects are checked before any more is removed, seem to make more sense for singers than doing a full-fledged UPPP. But that's based on many people's impressions and not based on good science. So the answer is you're not going to be certain what's going to happen until you do it. Now, if you have major oxygen desaturation, you absolutely have to do something.
Okay. Thank you very much.
You're welcome. Does that help?
Yes. Yeah, I didn't think that there was any research that had been done on this, but I just wanted to know if you had an opinion on it.
Well, my opinion is, for a singer, the less that can be done, the better, and you can always go back and do more.
Okay. Thank you so much.
You're welcome.
And thank you, Lisa. I would like to let people know that you do have control over the size of the video window in which you see Dr. Sataloff. You can drag the lower right corner to make it bigger or smaller. You can also drag the area in which his video window is in and make him larger than the NATS chat slide that is to the right of him. So you have these options, just so you know. Some of you are saying that it's a small screen. You control that, okay? Thanks so much.
Great. And I'm going to open Donna Bruno's microphone for her to ask a question. Donna, are you there?
I'm not sure my microphone is working.
It is, Donna. You're good.
Excellent. Okay. Doctor, good evening. My question is about over-the-counter medications like Advil and things like that. Are those dangerous for singers? Do they pose problems? And also, I have a lot of young singers who are considering taking oral birth control pills. Could you talk about that as well?
Sure. Advil, Motrin, other ibuprofen products create bleeding risks. So does aspirin. Tylenol, very little. The bigger problem is with aspirin. Aspirin interferes with platelet function, and it does it for the half-life of the platelets. So if you take an aspirin, you've increased your bleeding risk for 7 to 10 days. Ibuprofen is also effectively a blood thinner, and it will increase bleeding risk too, but it is out of your system pretty much in the half-life of the drug. So it's more like a 24-hour problem than a 7 to 10-day problem. Where you really run into risks is where you take blood thinners and all of the non-steroidal anti-inflammatory drugs like Advil and Motrin are effectively blood thinners. They interfere with platelet function so you don't clot right. If you take those medications in conjunction with another bleeding risk, such as a cold where you have a little mild laryngitis and the capillaries are dilated and fragile, or if you take those medications for menstrual cramps and you have a premenstrual hormone environment which also creates capillary fragility that predisposes to bleeding, you then have two insults that increase the risk of bleeding, and that can be a major problem. This is also true of any of the over-the-counter medications that contain ibuprofen or aspirin, which is also called salicylic acid. So when you see salicylic acid on a label, it means aspirin. Birth control pills have actually not been studied well since the new lower dose pills came on the market. In the old original pills, which had higher doses of hormones, about 5% of women had some voice changes, usually a little loss of high notes. With the birth control pills, those changes generally were temporary, and the voice returned to normal when the pills were stopped. With the low-dose pills and the estrogen-only pills, we have not been seeing as much of a problem, but again, there haven't been any recent formal studies on the newer medications. Now, those hormones differ from other male hormones, and they also differ from some of the birth control pills that are available outside of the United States. If people take male hormones like testosterone, androgens, for women they will make the voice change like a boy's voice at the time of puberty. That is to say, they will make the larynx grow, lengthen the vocal folds, and make the pitch lower permanently. We take advantage of this medically, for example, in gender modification patients, that is, people who undergo sex change. When people go from male to female, we often operate on their larynges to give them a soprano voice. In women who become men, we just have to give them male hormones, and their voices change, and they get a low-pitched male voice. So where might a woman run into androgens? Well, bodybuilding steroids. You know, those gorgeous, oiled female bodybuilders who get up on stage and pose, and then they come up to the microphone and say, "No, I never use steroids." Those are anabolic steroids, that is, male hormones. Those are the things that are outlawed in sports. They are also used medically. After menopause, women have a drop in libido naturally. Many women are not ready to give up their sex lives, and many of their spouses are not ready to give up their sex lives just because of the inconvenience of menopause. Turns out if you give women male hormones, their libido goes up. Who would have thought? So postmenopausal libido medication, male hormones, can cause voice changes, lowering of the voice. If you're menopausal or postmenopausal and making your living singing Queen and Serbinetta, those hormones could be the end of that career. So they have to be used with great care. Another place where women encounter those hormones is in the treatment of endometriosis. Endometriosis is a condition that causes painful menses, and it can cause infertility. Many of the first-line treatment drugs are male hormones. For singers, it's sometimes best to skip that step and move on to the next step. When people get male hormones and they still have pain from the endometriosis, the next step is to do a laser laparotomy, put a laser through a little tiny incision in the belly and vaporize the endometrioma implants. For some women, it might make sense for singers to just try and get the endometriomas removed if that's feasible, rather than running the risk of the male hormones. One last caution in this answer. In the United States, birth control pills contain estrogens, female hormones, and progestins. In other countries, including the British Isle, there are still birth control pills available that contain androgens. Women have a tendency to buy birth control pills when they're traveling overseas, because in many places you can get them very inexpensively, and in some places even without seeing a local doctor. Read the labels. If they contain androgens instead of progestins, you could end up losing a minor third on top before you realized what the problem is.
Thank you, Dr. Sataloff. As a follow-up, Larry Voitko has a question that I'll just simply read. Since aspirin increases bleeding risk, what can you say about those of us who are prescribed to be on a low-dose aspirin daily?
In some people, there is a sufficient medical reason to take a baby aspirin every day. The reason that it works in your heart is exactly the reason that it creates a risk for your voice. If there's a compelling medical reason to take a baby aspirin every day, then it's reasonable to do, but one needs to exercise a little extra caution. There are singers who have worse hemorrhage risks than that. There are people who are taking warfarin, Coumadin, which really creates bleeding problems, or Plavix, and still manage to sing. They just do it at increased risk. So if that happens, people need to be very careful to sing correctly, to continue studying long-term, which we should all do anyway, including those of us who teach singing, to avoid singing in borderline situations. For example, if you have a mild laryngitis, especially if you have a mild laryngitis and you're premenstrual, you've already got 2 strikes. If you're also taking aspirin, then maybe you need to be a little more willing to cancel a performance than you might be if you were not on aspirin and didn't have that extra risk factor. Sometimes you just don't have a choice and you have to use aspirin. For most of the other conditions, like arthritis, which many people still treat with high-dose aspirin, there are almost always therapeutic alternatives that create less voice risk. For example, ibuprofen we talked about, Motrin and Advil. There's another non-steroidal called Celebrex, which works pretty much as well and doesn't have the same bleeding risks. So there are alternatives, but not for aspirin given for heart reasons.
David, did you want to?
Yes, thank you very much. We have several hands raised. I'd like to open up the microphone for Stella. Stella, go ahead.
Hello, Dr. Sataloff.
Hello, Stella.
Hi. I have a question about the ongoing discussion that we hear right now about the vocal fry epidemic, especially in young women. And I would love to hear what vocal fry is physiologically, and then also hear what you would say to an undergraduate student if you heard them speaking in vocal fry.
Are you asking about speaking in vocal fry, or are you asking about singing vocal fry?
Speaking, actually. Thank you for the clarification. I have several students that, especially when they get the beginnings of a cold or they're just tired, they come in and it's like, "Good morning, Mrs. Hastings," and I have a lot of them that are falling into the Kim Kardashian category. So speaking.
Good. Well, we'll talk a little bit about both. First of all, let's say at the outset that it is possible to do anything safely if you're an expert. We all know that from our training as singers and from acting training and from voice training for cheerleaders. It is possible to do the wrong things the right way. So we can't say that vocal fry is always abusive and always wrong. However, that aside, most of the time it is abusive and wrong. The kids especially, but I've seen it at every age, who walk around speaking lowly in vocal fry are speaking in the bottom, less than the bottom third of their physiologic frequency range. Most of them are not supporting. They're pressing, which increases vocal fold contact forces. If you look at their larynges with a flexible scope through their nose, in many cases you can't even see their vocal folds because their larynges are so firmly pressed side to side and front to back. In addition, physiologically, vocal fry has an extremely long contact time. If you look at modal voice and graph the contact time, you see, it's hard to do this with the camera, I'm backwards here. You see a sine wave so that the vocal folds are sort of a sine wave. The vocal folds are closed and open pretty much equal amounts of time during a vocal cycle over the course of a second or many seconds. In falsetto, the vocal folds often don't make contact at all. In vocal fry, the vocal folds are closed almost all the time. They open in little short bursts, but the closure part is far greater than in modal speech. So the vocal fry is telling us that people are prolonging their vocal fold contact and hence trauma, pressing their voices so that they are making them hit not only more forcefully, but so that they're using their resonator system less effectively. And very often when they're using vocal fry, they are not supporting properly.
Right.
So you have all the right reasons to have the hair stand up on the back of your neck when your students walk in sounding like that.
Right.
In addition, we need to say a word about vocal fry in singing. As I said, it's possible to do anything the right way. There are many people who look at vocal fry, done without effort, with good support, and with an open throat, as an indicator of relaxed vocal singing. For example, if you have a singer whom you can vocalize very gently, say a bass or a baritone, whose bottom singable note is maybe a G or an F, but who can vocalize on pitch comfortably in vocal fry down to a D or a C, a couple octaves below middle C. And then the singer sings for an hour and does a little cool down, and that vocal fry is completely gone, and he's lost maybe even the G or the F and everything below. There's a pretty good chance that there's tension in that voice. If that whole low end is still there and the vocal fry is still there, there are plenty of people who believe that that's an indicator that the technique was probably pretty good and that there's not a lot of residual tension, because you lose the vocal fry in singing when there's excessive residual tension and muscle spasm. Have you noticed that? Do you agree with that with your students?
You know, I can't say that I've noticed that, but I certainly will. This has piqued my curiosity towards that. So I just have them avoid frying in their singing voice. So I usually stop them from vocalizing to that extent.
Well, if they push it, or if they get lazy and don't support just because they're low and they can sing without supporting, then they're taking a risk.
Sure.
But there's nothing that says, as long as their throats are open and their support's good, that they can't go down there softly, gently, and experiment with the lower limits just as you experiment with falsetto in the upper limits.
Okay. Great. Thank you. I appreciate it.
You're welcome. Thank you for the question.
Thank you. We have a question typed in now from Lori. This question is regarding asthma inhalers. Do asthma inhalers cause vocal fold atrophy? And if so, are there any inhalers that do not?
Great question. Once again, I am giving you an answer based on lots of experience and lots of opinion and not any good evidence-based research. But the answer is most of us believe yes. And the biggest problem, the problem with atrophy, is the steroid inhalers. The high-dose steroid inhalers that are used for asthma are associated with chronic laryngitis, inflammation, with fungal infections, Candida yeast infections of the vocal folds, which are a pain in the neck to get rid of sometimes, and in the long term with atrophy as steroid use elsewhere is. This was especially true of the older asthma medicines, some of which aren't on the market anymore, medicines like Asthmacort, which had large particle steroid medication delivery that sat on the larynx. There are some newer asthma medications that contain steroids delivered in much smaller particles, which should go more to the lungs and less to the larynx. But we still try, until there's good research showing that they're less troublesome, we still try as much as we can to avoid steroid inhalers. Now, other inhalers have not been associated with atrophy. For anybody who doesn't know what atrophy means, it means wasting, loss of muscle mass. They have been associated with other problems, including chronic laryngitis. The vocal folds get red, the lubrication is not as good as it should be, the vocal folds can get a little stiff and inflamed, but so far nobody has convincingly noticed atrophy from the non-steroid inhalers. So if you have asthma, it is best to control it with oral medications and eliminate or minimize inhaler use. And if steroids are necessary, it's best to use the non-steroid inhalers whenever possible. And if steroids are absolutely necessary to control the asthma, then it should be one of the new small particle steroids like Asmonex, with the caveat that that's what we think, but we haven't proven it yet. Also, I should mention that for laryngitis or infections, most of us who take care of singers in large numbers do not use inhaled steroids. If you need a steroid effect on the larynx, it's better to get it with steroids by mouth, or if you need it faster, in the muscle or in the vein. But I don't think I prescribed oral steroids for a singer with laryngitis ever. Rarely will use them for somebody with a serious problem in the larynx like sarcoidosis. But even that is very rare.
Thank you so much.
You're welcome.
I'm going to open the mic for Blythe Walker, who I believe has a question about the postmenopausal voice, and remind our chatters that in the chat box, I'm going to post articles that Dr. Sataloff has written, and this one is about the longevity of the voice that will go along, I believe, with Blythe's question. So, Blythe, there you go.
Well, hi. Hi, Dr. Sataloff. It's nice to hear you, and thanks so much for all the great info. I was just, you answered some of my question a while back. I was just thinking you were talking about PMS and birth control pills and stuff, and I have a question from the other end of the spectrum about care of the postmenopausal voice, both my own and my students. I have quite a few of older, let us say, postmenopausal singers who we still feel very strongly and very committedly about our voice, and some of us are still working, and just wanting to hear what you have to say.
First of all, I am delighted that you have lots of older singers and that you're still working and singing. It is a spectacular activity as we age. There is no reason that it can't be done safely for pretty much as long as we live.
Hear, hear.
It does have to be done a little bit differently. This is not a plug, but some of you may know that Brenda Smith and I put out a book a couple of years ago on choral pedagogy for the older student. So older singers, just like older runners and older weightlifters, need to exercise and approach things a little differently than 19-year-olds, or they injure themselves. There are unfortunately not very many choral conductors, as everybody on the line knows, who even know anything about the voice, let alone about the young voice or the older voice. So we need to be fairly careful to teach our people to have appropriate exercises, appropriate rehearsal pace, to try and treat their medical conditions whenever possible with medicines that don't interfere with voice function, to be careful about having reasonable vocal expectations. If somebody who is 80 and not in great medical condition joins a choir filled with 18 to 26-year-olds and expects to keep up vocally over rehearsals in a busy concert schedule, unless that's a very well-trained, well-maintained singer, that may not be a very reasonable choice and expectation. So let's back off from singing technique for a moment and talk about menopause and hormones. First of all, if I asked most of you how old you are when you go through menopause, most of you would probably say something around 50. You should know as teachers that that is the center of the bell curve. Every once in a while you read in the tabloids about some 68-year-old lady in England or someplace who got pregnant. That's maybe 5 standard deviations out on one end of the bell curve. 5 standard deviations out on the other end of the bell curve is about 28. So natural menopause usually happens at 50s, but it can happen as young as the late 20s and early 30s. When women pass through menopause, they stop generating female hormones or decrease the amount that they generate, particularly if they're thin and in good physical condition. You all know that the opera's not over till the fat lady sings. Well, it turns out that if you are obese, not after menopause, but if you've been obese, there is extra ovarian estrogen production. And the fat lady actually does last longer on stage than the untreated thin lady because the estrogen levels are higher. I am not recommending 300-pound memes, so stay in good physical condition. But when you stop producing the usual amounts of estrogen, the male hormones that your body is producing all the time anyway are not balanced and they become dominant. So after menopause, the voice fundamental frequency, speaking voice pitch, for example, gets lower and lower over the decades. Less so, by the way, in singers than in non-singers. Exercise helps. Mm-hmm. And you develop other male-like characteristics, little hair on your face and the like. Those postmenopausal male characteristics and masculinization of voice can be averted by taking hormone replacement if there's no reason not to. Now, hormone replacement has a bad reputation because in some situations it may be a risk factor for breast cancer. However, those are very specific situations. I deal with this a lot. My wife is a breast cancer surgeon. There are many women who can take estrogens, take hormone replacement, stave off the hot flashes, stave off the other inconveniences of menopause, and maintain the top notes in their soprano voices, because over time, in most women of normal body weight with uncompensated menopause, you will lose some high notes and lose some vocal efficiency. It isn't necessary, and there are lots of women who do not have a legitimate medical reason, a history of breast cancer or a high risk of breast cancer for genetic reasons, for example, and who are just told, oh, you shouldn't take hormones, you might get breast cancer, when there's no medical reason why you can't take hormone replacement. That's something that requires expert individual consultation with a physician who really knows the literature. So it is possible to maintain the voice for years. Now, over time, there are some aging effects in males and females. The bulk of the vocal folds, the number of nerve endings, the thickness of the mucosa all change. Lungs and thorax lose their elasticity and distensibility. We all have some aging changes. They don't necessarily need to end a career or even end a fach in most people. The things that we usually think about as aging changes in the voice, the big wobble and the loud, flat volunteer in the church choir, are not irreversible aging changes. Mm-hmm. They are bad conditioning. Mm. Just like the person who can't walk up a flight of stairs without stopping twice and then has a heart attack and gets put in a rehab program, and 6 months later he or she is walking 3 miles briskly. So the inability to walk upstairs wasn't because she was 70 years old. It was because she was out of shape. You can take those older singers, get them into aerobic conditioning so their lungs and abdominal and back muscles get re-strengthened under medical supervision, and take them back into the studio, just like young singers, with patient gradual vocal exercises, and take decades off the sound of those voices. And for any of you who has to go to church and listen to those singers. It's a worthy public service.
Thank you, Doctor. You've verified my philosophy and my activity that singing can be a lifelong activity, and thank you so much.
You're welcome. Keep singing.
And thank you. We have another question now from Carrie. Carrie, I'm going to unmute your microphone as soon as I can find you. There we are. I do want to remind everyone we are 15 minutes away from the end of our session here. So if you could ask your question as concisely as possible, that would help everyone. So we can get through. We have a lot of questions still to be asked. So Carrie, you are live. Go ahead. Oh, maybe not. Let's see. You are self-muted, Carrie. You are self-muted, so I cannot unmute you. I will read your question aloud. Carrie has said they have a student who's diagnosed with MTD and has been to a specialist in Chicago. And she's now working with that student together to alleviate symptoms. Could you address this condition and, if possible, suggest some vocal exercises that they might use to work together?
Sure. MTD stands for muscle tension dysphonia, which is a fancy word for using all those muscles in your throat that you're not supposed to use. It's what singing teachers deal with every day. It's the low, pressed, pushed voice, using the muscles in your neck and throat instead of support. When it's a singer, it's often very helpful to work in conjunction with a speech pathologist. As everybody on this call knows, singers have so much ego tied up in their own sounds that it's often very difficult to get them to change. However, sometimes they're not nearly so protective of their speaking voices. In our setting, in my office, we have everybody work with a speech pathologist and singing teacher, singing voice specialist, at least initially, including our singers who don't think they have any speaking problems, working with a speech pathologist, and our non-singers working with the singing voice specialist. In many people, singers especially, they will be comfortable making changes in their speaking voices and learn techniques that they can carry over into singing. So that's often helpful. I will, since you asked for some specific suggestions, I will be happy to give you some suggestions so long as you understand that they're coming with my singing teacher hat and not with my otolaryngologist hat. There are a zillion different techniques. None of them works with anybody, but with the really tough ones who get referred to you out of medical clinics or who are taking their first lessons after they've been singing successfully for a decade, I will often start them not making any sounds at all, just having them breathe, looking in a mirror until they get to the point at which they can breathe with their tongues relaxed, sitting gently against the back of their bottom teeth without doing anything. Some of them it takes a long time just to get them to be able to breathe without tensing. Then I will try to get them to flex and relax abdominal and back muscles without having any muscle change in their necks and mouths, and breathe with the muscles flexed and relaxed. Because I think if you can't just open your mouth and breathe and open your mouth and tighten and relax your support without tightening your neck muscles and pulling your tongue back, there's not much of a chance you're going to be able to sing or talk. After which, I'll have them sigh on any note at all, and that'll be the note that we start with. And it's usually building a half step at a time, and the exercise stops whenever they get to the point at which the tongue comes back and the neck muscles tighten and the jaw tightens, and you're seeing muscle tension dysphonia or hyperfunction, however you want to call it, in singing. There are lots of other ways, but that's just one sample approach that I found has worked well in those kinds of patients. Just dissociate them completely so that you tell them right up front you're not going to ask them to sing at all, and see how long it takes them to be able to relax. Does that help?
Yep.
Are you still there?
She's not on mic, so we'll assume that it is.
We'll go and we'll move forward. I'm going to read Jonathan Voss. He apparently has a puppy who's making too much noise to open his microphone. So he asks, in understanding the work you've done in collaboration with Dr. Brenda Smith, I was wondering if you could discuss your views on which inhalatory breathing techniques do you prefer, how do you teach it, and why, and does it change for the different music styles, classical versus non-classical?
Hello, Jonathan. Jonathan, if you don't know, is the laryngologist you should see if you have a problem and you're in Milwaukee. I presume that you're asking about inhalation technique and not inhalation phonation technique. And I'm deciding whether to bail on you completely in this sea of singing teachers, but I won't bail completely. I'll just say this much. There are a lot of different ways to teach respiration, inhalation and exhalation, that is, breathing in and support. Any of the ones that generate tension in the throat is probably not good, and any of the ones that don't can be taught well. There are some basic physiologic principles, however. Singing teachers and singing students often concentrate very hard on abdominal breathing, and indeed it is correct that when singers breathe effectively, the abdomen expands below the rib cage and it expands in back too, just below the rib cage. The big problem is many singers get so fixated on the notion of abdominal breathing that they don't pay any attention to the amount of air in the chest cavity. If you want to squeeze air efficiently out of the top of a balloon, do you want a half-full, soggy balloon or a completely full balloon? Well, you want a completely full balloon because you put your hands on it and you almost only have to think the hands together. You're compressing a fixed amount of gas in a container by making the container smaller. The more gas that there is in the container and the more pressure it's under already, the less the gross motion you require. So singers need to be singing with the chest as filled as it can be without creating any tension in the muscles above the clavicles. So they need to work against a full chest and have the active breathing be abdominal. Now there are lots of ways to teach that. One of them is to expand the abdomen and back. Another is just to relax and let the air come in. Another is to expand the bottom of the rib cage. They are all imagery. So long as the teacher understands physiologically what he or she is trying to accomplish, and so long as the teacher is willing to change languages and change imagery for the students who don't get it with the first choice description, it sort of doesn't matter. I kind of believe that's true with almost everything we teach. I've been teaching for a long time, and I can't say that I know anything that works equally well with every singer I've ever seen. We have to be able to say it a lot of different ways, but we also have to know enough not to believe the language that we're using, because all of the imagery is just that. You know, we tell people to relax all the time. If people relax, they'd be a bowl of jelly on the floor. We don't really mean relax. We need to know what we mean and have lots and lots of different ways of communicating that to the singer so that he or she produces what we're trying to get rather than what we're trying to say. And that's just as true with inhalation as it is with singing a note on with proper support and an open throat.
He has a follow-up question, and I think it may be our last, unfortunately, but Jonathan says it is a very popular technique in the Northeast to use the voce di strega in teaching a healthy belt rather than bringing the weight of the thyroretinoid dominant register up their range. How would you instruct musical theater singers to sing today's rep that demands a very high belt?
Jonathan always asks great questions. There are lots of misconceptions about belting. The first thing somebody needs to understand about belting, no matter what other technical approaches one wants to take, is that great belters are not shouters. Whether we're talking about the current high belt trend in adults or whether we're talking about these poor 8 to 11-year-olds trying to sing Annie, if you listen to the ones who end up in our offices, they are of fairly constant volume with very little change in vocal output and are essentially shouting. When we teach classical music, in addition to teaching technique, we often encourage people to listen to recordings of great artists. If you're teaching a tenor, you will want that person to listen, probably, at some time or another, to Pavarotti and Gili and Bierling and Melchior, and to listen to a range of techniques and finesse on and with notes. In the belting world, people need to pick up the Ethel Merman recordings. If you listen to and study a great belter, and I think most people will agree that Merman was as great a belter as we've had, you will have trouble finding a single note that is the same from beginning to end. Her variation, note by note, whether it's volume, vibrato, pitch, or all of them, is infinite. So, if people are going to belt at all, and especially if they're going to try and carry a belt mechanism, essentially a chest mechanism, higher than it should be, which I don't recommend. We'll get back to that in a second. At the very least, they should be doing it with very distinct variation in the voice on practically every note they sing. Now, most singers can create that same kind of belt effect by inflection and by style, rather than by carrying the laryngeal position of chest voice into the highest notes. And the audience can't tell the difference. And it's much easier and much safer. And that's what I recommend, but whether people learn how to do that and get that style without having it suddenly go from belt to sounding too legit, or not, they do it using a more legit technique, stylized. If they do it loud all the time, Jonathan, they're going to end up in your office or mine.
Thank you, Dr. Sataloff. My goodness, what a very full hour. It goes so fast. And I'm sorry for those that have questions still, but come to the Voice Foundation meeting the end of next May and find Dr. Sataloff and ask him at that time. But thank you, Dr. Sataloff, so much for this wealth of information and your generosity tonight.
Thank you, and you will also find Carrie and David if you join us in Philadelphia for the Voice Foundation.
Yes.
Thank you all for your wonderful questions, and NATS, thank you for putting this together. It's a great format.
Thank you. We'll see you all December 14th for Matt Houck, and have a good evening. Go ahead and you all can sign off now, and David will close you out as well.
Yes, thank you all for joining us.
Thank you. Good night, Dr. Sataloff.
Good night, Carrie. Good night, David.
Good night.
I feel like somebody should say good night, Chet. Have a nice night, everybody. Thank you. It went very